Remember, the answer to this question is do not wait. And we shift as of today. If you have any patient on AS or ARB whose ejection fraction has not shown improvement at least, or has shown a very sluggish or staggering improvement, each and every of these patients should actually be switched to ARNI. Because you think that a patient is stable while they are not. As I told you in paradigm heart failure, 20% of the stable patients actually died or had a primary event during the course of this trial. So what might appear to be stable disease is actually not stable. People keep on dying despite looking very stable. So there is nothing called stable heart failure. The patient is just compensated or they are decompensated. Everybody else is on the death row. So remember, any patient who is showing an illusion of stability is actually luring you into complacency and might actually kill the patient. So you want to reduce heart failure hospitalization, you want to reduce death. Each and every patient of heart failure with ACE and ARB should immediately be switched over and started on ARNI. So do not wait for certain forms of deterioration. And these are your current recommendations. The current recommendation for class 1A in patients with 2 or 3 symptoms, use of ARNI is recommended to reduce both morbidity as well as mortality. ACE and ARB only when ARNI cannot be given for certain reason. Those reasons are actually such few and far in between that you will hardly find any patient who cannot be given ARNI but can be given ACE or ARB. Second question is, do you think that a patient who comes with a known heart failure and gets decompensated different from a patient who presents for the first time, that is de novo heart failure? Again, yes, these two classes of patients are dramatically different. So acutely decompensated chronic heart failure, patient looks maybe older, would have a worse baseline status and lab findings, and de novo patients are the ones who do not have a history of heart failure. There are certain comorbidities associated with ADHF patients which may not be seen in de novo heart failure, although not always so. There are certain triggering agents who are chronically compensated patients, while here it may be more ischemia or valvular disease. Presentations in the decompensation are more like dyspnea, orthopnea, ascites edema, while here in de novo heart failure they may most likely present with acute pulmonary edema or shock or a combination of these two. So de novo patients are quite different from the patients who are presenting with acutely decompensated heart failure.